Good afternoon, everyone. I bring greetings from Dayanand Medical College and Hospital. I'm a professor of surgery there. At the onset, I'd like to tell you that I am only a general surgeon. I was the junior most guy in my hospital in hierarchy in the department, so I was handling wounds. I do a lot of hernias and everything. So this little profession of mine became a passion, and now it's a full-time profession. So without wasting time, why do we need early prediction of infections? So early prediction would help us with early interventions. The goal is amputation prevention. We have to look for effective interventions. We have to save patients' time and our time as well. There are resources at stake. We'll be wasting a dressing if it is not effective. And somehow we need to know what is working for the patient and what is not. Most important in the Indian setting and world over is cost. So if we are fast, we're able to save money. The elephant in the room is antibiotic resistance. Overuse of antibiotics. If we know if a wound has infection or not, we can stop this overuse of antibiotics. So this is a big elephant. So if predictions of infections can help in saving antibiotics and saving the patient from antibiotics, we have won. So I'll be talking about this device, which is so-called a game changer in the antibiotic resistance space. This is from a startup called Adveo Diagnostics, a device called Illuminate, in which they've reverse engineered an MI phone, an Android-based phone, and put additional sensors on it. So there are a few publications that have come out, and we are looking at our own data for publication right now. So what it basically does is that UV light and visible light is thrown over a wound. If it is infected and has these bacteria, their cell wall, which is rich in porphyrins, infectious material, NADH, and flavins, they will react differently to light. So if they react differently to light, gram positive and gram negative will emit different color. Red will be shown as gram positive and green would be shown as gram negative. So if we could teach machine learning, use these to teach machine learning, and we could have AI give us what sort of infection is in this wound, it would be very helpful for us. So this is the device Illuminate. So been using it for a year. So what it gives us is something like, in Indian mythology, we call it the Tisri Aankh, the third eye. So what is not visible to the usual eye, the third eye, would give us predictions of infections. So it helps track treatment efficacy. So what's working in the wound and what's not. So this is the device that gives us label-free infection detection, gives us classification of bacteria, differentiates colonies from commensals, is non-invasive, generates a report at the end. You can involve families and plus you can use all this data for publication purposes. So I'll not waste much time. Let's come to case scenarios, how I have used it over time. So amputation prevention. This was a 56-year-old gentleman with a toe ulcer that looked like an ideal candidate for amputation. So I debrided the wound and started imaging the wound. This is my first patient. So you know that this patient with somewhat the joint involved would land up into osteomyelitis and stuff like that. So we would know that there is infection in the wound. We would take cultures and perhaps put patient on antibiotics. So with serial tracking of the wound, the infection went off and our final picture was like this. One limb saved. So we could use it for post-debridement monitoring. This is a patient where there was paronychia in this diabetic patient. We had done debridement and removed the part of the terminal phalanx. So we had infection to start with. We take tissue cultures to prove gram-negative infections. Then serial dressings were done and this wound eventually healed. One could use, as I've told you, antibiotic resistance. One could use targeted antibiotics. Know when to use antibiotics, know when not to use antibiotics. Again, a patient, a 73-year-old male. This is post-amputee. You could see that second, third, 4 digits absent. We could track infection, and I think so this was Pseudomonas. gave some Ciplox according to sensitivity, and eventually this patient healed again. So you can decide about choice of intervention in sick patients. So this was an elderly female diabetic patient with CLD, cardiomegaly, EF about 25%, very obese. So this is her initial presentation with this ulcer. So we saw that, it was dirty, we debrided, continued monitoring this patient, gave her proteins and followed our hepatologist advice as well. As the wound was getting better, I decided to vac it. And as we did serial tracking, vac was keeping the wound clean. So eventually they went home, did dressings and magically came back with this, and I thought I'll image it also. So serial tracking of an ulcer is done, timely intervention, the antibiotics. I'm just being very repetitive, but again, all of this, so we could take cultures from here and and these patients heal again. So another interesting aspect is when we saw this for the first time, we thought that the device is fooling us. So capturing mixed infections. So this is like the ultimate capacity with which you can test this device too. So we had this young 40-year-old patient. So this is 40, traumatic ulcer, he's diabetic. Again, had to debride it, thought there was a foreign body, removed it. So this culture report had Acinetobacter baumannii and Staphylococcus aureus, gram negative and gram positive. So this is what the device was showing. I thought I'll take both cultures from it, and we had proven infection, and eventually the patient's wound started contracting again. You could see mixed infection again. So eventually I think I secondary sutured the wound. Difficult cases, where to do amputation, how much of midfoot amputation, difficult attendance sometimes, difficult old age friends to deal with, would not be very subjective to listening to you most of the time. Again, this gentleman, I debrided him multiple times. You could see the wound on the left. The little toe was about to go off, still was not interested. So this was the final result. So again, these patients magically from rural Punjab don't listen to you. This guy is driving a cycle these days. Again, this we could track infection, had to convince that this green is the infected part, we need to remove it. So eventually did amputation for him. This is the imagery. In fact, this was the lateral ulcer that he had, and the final result I've shown you. So another interesting aspect is tracking progress of negative pressure wound therapy. So we have sent this for presentation at the American Hernia Society meeting this September. So where we have been serially tracking our negative pressure wound therapy wounds and seeing whether, the infection is going off the wound with negative pressure wound therapy. These companies, 3M and others, they say that, they would suck out the bacteria, but I needed proof. Another mistake that I was making in my practice, I used to send the foam for culture. And invariably that foam used to have E. coli or something, and I would put patients on unnecessary antibiotics. So what I did was, eventually, when these images came out clean, I've stopped giving antibiotics when the patient is on NPWT. So you could serially track this wound. This is a patient, I did not do below-knee amputation for him, but it's done by my ortho colleague, came to me with wound issues that this is like draining pus most of the times. So we again imaged the wound, saw this gram negative, eventually applied VAC for this patient. Very confidently applied VAC, but did not know that this sort of imagery would come where there would be no infection serially. So the wound secondarily healed. Most of my patients are very difficult and they don't agree for skin grafting. So excuse this so that these patients usually are dressed and the wounds heal. Timely surgical decisions in difficult patients. Again, this patient with a second toe infection, osteomyelitis, debrided, removed the toe, but the infection kept on persisting. You had MRSA in this patient. Again, once MRSA was treated, you had gram negative in this patient. So in fact, after this, the sole was infected. I had to do debridement, and these are the imageries from the sole of the patient, gram negative again. Convinced them, they did not have money, supported them. 3M sometimes helps me with free vax for my patients. So the infection kept getting lesser and lesser. And eventually, this is what I was left behind. So once you combine artificial intelligence with NPWT, you can salvage limbs. I have a numerous number of patients. So this is a patient I had done below-knee amputation on the other limb. So this guy flew off from US because of this little toe ulcer, and he was very apprehensive. And see the turn of events, that this little toe ulcer, despite me doing dressings, was infected, increased, and eventually led to toe amputation. So you could see that photo signature with gram-negative infection. And eventually with dressings this wound healed too. So sometimes you have to hit the ulcer hard, take it as a challenge and do your best. This is a patient with a lateral ulcer on the lateral malleolus. Again, a very difficult patient because he wants to have alcohol every day. So dirty ulcer needed debridement. You knew where the infection is. We could take cultures, put the patient on antibiotics. The infection kept reducing, and again he was not convinced for skin grafting till I made him, told him that you need skin grafting. So final results were these. Tracking infections, monitoring, plan for grafting. Again, a difficult patient from Jammu and Kashmir, young diabetic, 40-year-old diabetic patient. Somebody told him that his foot would go off, but I did aggressive debridement. Then used my wax to get the infection off, and we were able to do skin grafting for him. This is an interesting case of maggots. So this is a patient, diabetic, came with maggots. I can't focus here, but the lateral parts of the great toe had maggots coming out. So I thought, let's image and see what will happen. See, maggots is used as debridement therapy. So they would eat on bacteria. So no fluorescence was detected. So once we used, once we treated out the maggots, the opportunist infections started coming. So little gram-negative, this patient is fine. So this is another patient, we lost him eventually, very close patient of mine, a radio singer, elderly gentleman. I had done amputation for him, amputated the other limb long time back. So again, had big, great colonies of gram-negative infection. Debrided the wound multiple times. Eventually re-debrided it so that there is no infection. So it proves that once you re-debride, perhaps you would reach the level where there is no infection. This is it. So this is tracking and documenting of surgical site infections. I did not put my abdominal wounds specifically here because the talk was diabetic foot ulcers. So this is what I presented at European Hernia Society meeting. It was among the top 10 abstracts, oral abstracts at the meeting, where can AI help in early prediction of surgical site infections. So what we did is we started using our SSIs or SSOs, occurrences, and started imaging them. So we can in time differentiate between hematomas, seromas, and actually infections. So we are about to publish our series of about 45 patients. So this is something new. So we could track infections inside surgical sites. So tracking mixed infections I've already covered, I would not speak on it again. So see, in 2029 perhaps the iPhones will have so many cameras. We expect technology to reach a level where perhaps an amalgamation of our surgical clinical experience with technology may lead to third eye, fourth eye, fifth eye, sixth eye, or seventh eye. The take-home message is, it is very important to monitor wounds. Digital photography and smartphones hold the challenge, hold the key for it. But we need to have standardized data sets. Even if you see my images, there is no standardization. My staff has not been properly told what to do, how to be in the center of the image. Those things have to be standardized. Proper image labeling is required, and accounting for patient variations. My North India data set might vary from a South Indian to an Australian data set. So one needs to empower both clinicians and patients. One needs to get families involved as well. So this sort of imagery would get the families involved. You could tell the patients and families that this is working and this is not. So they're always at your beck and call, so to help you out. So technological advancements can improve patient care and equip clinicians with more accurate, timely information. This is the image I clicked today at the Indian Institute of Science. What a beautiful campus. Thank you so much.